Welcome, class, to Chapter 9. Like I was telling you before, Chapter 9 does hold a lot of good things, so I'm going to try and accent all that you need to know to be successful out in the field and, of course, to pass your national exam. I know that we are doing this lecture online because this is a holiday time, and I just want to wish you all the best. Many blessings to you and your families. I want to take a special moment just to say thank you. I am very grateful for all of you. You guys are such a fun class, and I just enjoy teaching you so much. It makes my job a lot easier, and I'm not kidding when I say that I know all of you are going to make fantastic phlebotomists. So without further ado, let's jump on in. First, we want to talk about fasting samples. Fasting is from 8 to 12 hours, so minimally 8 hours of not eating anything or drinking anything with sugars or carbohydrates inside of that. So that does mean that they are allowed to drink water, and encourage your patients to drink water. If somebody goes 12 hours without eating or drinking anything, their veins tend to run and hide on us, and they can become a difficult stick. So you want to tell them to continue to drink water, but don't drink any coffee, juices, or anything, and definitely do not consume any foods. Now, on your exam, this is a span 8 to 12 hours, but if it asks you the minimal amount of time, then you will know 8 hours. NPO means nothing by mouth. That literally means no water, no anything. When our patients have an NPO status, they can have little bits of ice chips, meaning that they can chew on some ice, but we don't want it to be excessive because generally NPO means they're going to surgery. If somebody gets put under anesthetics, their GI tract will literally stop working. And if their GI stops working, then everything inside of it has a tendency to come out. This can make surgery very tricky. But as far as we go, fasting 8 to 12 hours, NPO means nothing by mouth, and this is usually collected in the morning, so that way somebody does the majority of their fasting while they're sleeping. They wake up and come to the clinic or to the office and have their blood drawn first thing in the morning. But we do want to confirm this. And please do not lead the patient to this. Don't ask them, how long have you been fasting for? Or what did you eat breakfast this morning? Because a lot of people get confused. They think breakfast means this big old meal, when in all reality they ate a banana or they ate a grapefruit. That still breaks our fasting. So we want to literally ask them, when was the last time you had something to eat or drink? And hopefully the response is, well, I've been drinking water, but I haven't had anything to eat since 8 p.m. last night or 6 p.m. last night. Time samples are very common for us out in the field. Time samples generally mean that they needed to take a medication at a certain point in time, and then we were going to follow up and then see what level of medication actually made it into the bloodstream or not. So therefore, our time samples must be collected at that specific time. The very, very most important thing that I need to stress here is that you cannot fake this. If you're 15 minutes late, you need to put the proper time. That way, the doctor and the pharmacist do know at what time the time sample was collected, even if you are late to collect it. Very, very important. They base all of their medications, diagnosis, everything off of this. So just use the honor system, and if you're running late, let them know that it was a late draw. They may be able to use this data, and if not, that's okay, they'll reorder it. You don't want them to go forward with the patient care when it's not necessary or using inaccurate data. As I was mentioning before, the main reason to do time samples is to hit that therapeutic drug level, which means that this is the optimal point in which that medication is actually doing its job. So we need to know how much dosage we need to give somebody to reach this therapeutic drug level. And this is very key because if somebody's taking blood thinners or if somebody's on antibiotics or anything like that, we need to know what the optimal point that it is reaching and if that optimal point is actually going to be capable of treating their disease or ailment. These are actually pharmaceutical terms, but they apply directly to medication. And so I want to just take a quick moment and go over these. Drug half-life refers to how much medication actually makes it into your bloodstream. When we ingest a medication, let's just say acetaminophen 500 milligrams, chances are only 200 to 250 milligrams are actually going to make it into our circulation and have an effect. Our body is going to filter out the rest of it and essentially excrete it. Now, concentration of medication, we all know that we use a lot of preservatives in our medications, fillers as they're referred to, and so depending on how potent and powerful the actual concentration of the medication is, will affect the drug level inside of that individual. Also, the way we administer it. So if somebody takes it orally, we have the drug half-life effect, and we may not see that large of a dose actually make it into the circulatory system or into circulation and usage of the body. If we give somebody an IV and we directly inject the medication into their vein then we're going to see a direct effect and they're going to have a larger absorption of that medication, and it's going to hit them a lot faster as well. If somebody puts on topical cream, something just right on the skin, then we will also see a difference in how fast that medication works and how much of the medication is actually absorbed. Now, age of the patient does affect how much the drug level is inside their body. I like to tie the age down to metabolism as well, because our metabolism does slow the older we get. And if the metabolism is slower, then of course we're not going to be breaking down and absorbing as much. Now, the weight of the patient, and I like to use a kind of bad analogy here, is I'm sure we all have a friend or family member who is larger and can probably consume more alcohol than the average person. And so the same thing happens when we're talking about medication and drug life. The weight and also size of the patient will affect how much of that medication is being absorbed and put into use. Liver function and kidney function, as we learned in Chapter 3, these are our filtration systems. They're the ones that really take out any of the toxins or preservatives or any additives, and in fact they filter the medication as well. So if your liver's not functioning very well, then it's not going to filter a lot of this, and we're going to see an increase in that medication into your bloodstream. Same goes for kidneys, but kidneys work a little bit more with dilution and osmosis and how we are actually absorbing this medication. And then disease state plays a big function into how the effect of the drug will actually be on the person. And all of these things we need to take into consideration when we are going to actually administer medications. But for us phlebotomists, we need to take all of these into consideration when we're looking at doing our draw for our peak and trough value, which we're going to talk about here in a moment. And this is one of the main reasons why we have to be very timely with our draws. If it says a half an hour after the sample was given, then we need to be there a half an hour after that sample was given. Time samples continued here. This is where I want to talk about the trough and peak value. If you think about peak value being a mountain, right? You climb up the mountain, the very top peak is the absolute largest value that we're going to see the medication have. The therapeutic range we want to aim for to be right at this peak level. Trough means before the sample is given. So We do want to draw blood before to see where the blood is at and how much medication is still lingering, maybe from a previous dose. And then we want to draw at that peak level. Now that peak level will be told to us by the physician. It will be ordered on a requisition form. So we will know that it was given at, let's say, 0300, and we need to be drawing the blood an hour later, so that's 0400. When we are collaborating on what time the medication was given, we need to discuss this with the nurse. This is very important. You may think that we need to discuss this with the physician, but the nurses who is responsible for giving this medication and recording, charting when the medication was given. So we always want to check this with the nurse. Now the peak and trough levels are given to the pharmacist, and the pharmacist can alter the dosage, can also alter how fast the medication is being given, and all of these things will play an effect to the sustainability of that medication inside the patient. And we really want to hit this therapeutic range, so therefore we know that we are doing the best that we can for our patient, and given previous studies, we know if we hit that level that the person will be able to get rid of a certain disease state, or it will increase or help a certain disease state. Stat samples mean drop everything and go collect that sample right then and there. The moment you receive a stat sample, you need to take that as your highest priority. As soon as possible is also very important and needs to be taken seriously. Let me use a real life scenario though to kind of outline this. So we all know this stands for as soon as possible. As soon as possible, you're going to do a timed sample draw, and you are going to be right on time. You're walking towards the door, and all of a sudden you get a page and you are given an ASAP draw. It's okay to finish your time draw and then go to your ASAP. Now let's say you're walking on the hallway, you're right on time for a time draw, and you get paged a stat sample. At that point, you have to abandon the time draw and go do the stat draw immediately. Now, we are moving into a subject that does require a little bit of extra documentation because this is going to be used in the court of law. And the first thing that we're talking about here is alcohol testing. And it's exactly what it sounds like. When somebody refuses to do a roadside or is demanding a blood alcohol test, then they will come in and we will need to draw their blood. Now, the really important thing that you must remember for doing this is you cannot use an alcohol-based antiseptic. And with that said, betadine, providone, iodine all have alcohol inside of them. And what happens is when these samples get turned into the court, the person who's in question, all their lawyer has to say is, well, the phlebotomist used an alcohol-based antiseptic, so therefore that blood is tainted. We can't tell if some of that alcohol entered into that blood and altered all of the tests. So no matter how much evidence is present, the judge will have no choice but to throw those results out. And therefore, it's very important that we support the court system with the most accurate results from our specimens. So always remember, when we're doing blood alcohol testing, we must use chloroxidine or benzochloronium chloride. These are our two antiseptics that don't have alcohol-based. We, of course, don't want to use hydrogen peroxide. That will make the veins kind of run and hide. We don't want to use alcohol, betadine, or providone iodine because of their base alcohol presence. As I was referring to in the previous PowerPoint, this does lead to extra documentation whenever we know that the sample is going to be used inside of the court of law or our judicial system, however you want to view that. Now that special documentation is called the chain of custody. So we do the chain of custody for 4 different types of tests. One being paternity DNA, so if we need to know whose dad this is, different things as far as molecular diagnostics, then DNA and paternity testing will come from this. Also, like we were just talking about in the previous slide, blood alcohol testing will also need chain of custody. Any type of drug infarction, meaning illegal drugs such as heroin, cocaine, marijuana, any of those will need to be tested with the chain of custody as well with it. And then also our last one is any type of poisoning. So if somebody feels as though they have been poisoned, arsenic, lead, zinc, then that will also come under the chain of custody. And I know this is going to sound like a terrible analogy, but I always think of the movie Aaron Brockovich. All of those people were being poisoned through their water, and if you were assigned to a case like that, then you would have to use the chain of custody, knowing that that would be used inside the court of law for trial. But let's talk quickly about the chain of custody. This is an extra document that accompanies the sample, and that's really what I want you to focus on. So whenever the sample is actually collected, the phlebotomist must record that they collected it at what time, and then who they actually hand the sample off to. The person receiving the sample must document the time they received the sample and everything they do with that sample, and then the time it is handed off and handed off and handed off. And essentially what is going to happen is when the judge is sitting there looking at the chain of custody documentation, they need to be able to see the moment the blood was drawn all the way from where the results were obtained and then how the results were shared, and there cannot be any gaps in between one person to another. Otherwise, we can't guarantee that the test was done accurately, and it cannot be used inside of the court of law. So anytime you're going to do a chain of custody draw, you must document everything you did with it, the time you had it, the time of possession. As I was saying in the previous slide, one of the items that will require this chain of custody is poisoning. Heavy metals, arsenic, lead. We do use a royal blue top for this. It is very, very important that we do cleanse the site very thoroughly so that there is no excessive or cross-contamination from anything that may have already been present on the skin or clothes. Now this should be rather refreshing because we talked about this on the very first day of class. But therapeutic phlebotomy is just a fancy way of saying bloodletting, and we know that people who suffer from polycythemia vera and also hereditary hemochromatosis are essentially in need of therapeutic phlebotomy. And we will drain roughly a pint of blood, and we do this just as if they were donating at a blood donation center. The drawback with this, though, is that we can't use that blood. So essentially we drain the blood and then we have to discard it appropriately in our biohazardous waste, and it does have to be taken care of. These individuals do kind of know when this is coming out of balance. They will feel lethargic, they will have other signs and symptoms, and then will be coming back to see us. When I was working out clinically, I had a couple patients who had this, and one gentleman generally had to come and see us every 2 to 3 months to maintain homeostasis. So please remember polycythemia vera. It is one of the only disease states that we still practice therapeutic phlebotomy for. Now, let's go ahead and define blood smears. Now, I know we've all made blood smears in the lab, but why? Why do we make blood smears? Blood smears are for a white blood cell differential, and if you guys remember, we're differentiating which white blood cell is elevated in the blood because that will give us an indication of what type of infection is going on inside that person. So we make blood smears essentially to diagnose what type of infection is present. So once again, we're kind of looking to see if there's bacteria, viral, allergens, whatever the case might be, so that we know how to do that. Now there are some parameters around this, and I just want to remind you guys, I know we talked about this when we were in lab, but you will want to put about a 1 millimeter droplet of blood on your slide, about a ½ inch from the side. You don't want to use a dime-sized droplet. If you remember, if you have too much blood, we can't smear it thin enough to create our feathered or tail edge. And inside that feathered tail edge, when we have smeared it, it becomes 1 cell thick. And when it's 1 cell thick, we can take our microscope and we can analyze the edges. And as we look in there, we can honestly tell the difference between one white blood cell from another white blood cell. And we will essentially count those, or at least we used to. Nowadays, a computer really does this for us. I'm certain there's some old school places that still do a manual count, but computers really have replaced this. Now you want to take your smearing slide edge glass smear and you want to hold it at a 30 to 35 degree angle. You don't want to go much more than that. You can cause damage, hemolysis of the cells, and then it's going to be very difficult to differentiate them. We also use EDTA blood, which is from a lavender top, and it must be processed within an hour after collection for a relevant blood smear. And I believe that is all for blood smears. As the class has been progressing, I hope that certain things are just starting to trigger for you. When you hear blood glucose, I hope you're already thinking sugars, diabetes mellitus, but we have a series of different tests that we will do to diagnose or determine if somebody has diabetes mellitus, which, as you know, is a insulin producing disease, and it could either mean that it's overproducing or underproducing. And essentially insulin is what breaks down sugars inside of our body. And sugars are actually a very large molecule. Without this breaking down, it can cause our body a lot of damage. Not to mention, without breaking it down, it's hard to feed our brains, and it's hard to keep a lot of our internal organs working properly. Here our book is going to define 3 different types of diabetes. In all actuality, there's quite a few different types. But let's just talk about the most recognized, and that is type 1 means that you are insulin dependent. So that means that every time you eat, anytime you want to break down sugars, you do need to take an insulin injection. Type 2 is when there is a lack of insulin productivity, or if the insulin is not working correctly, and a lot of the times this can be balanced with diet and exercise. If type 2 is not taken care of, it will turn into type 1. So therefore it's very, very critical that we explain to patients that have type 2 diabetes that they don't want to fall into type 1, that they still have an opportunity to fight this and to live somewhat of a normal life. Now, with that said, this is going to be one of the largest challenges you face inside the healthcare industry, is getting people to change their lifestyle. I can't tell you how many times I've heard my patients say, well, if I can't eat that, then there's no reason to live. Or if I can't do this, then why even live? Well, I know that a lot of the times when we receive bad news, we have a tendency to reject that news, and I just hope that down the line people find other reasons to continue to live and to change their lifestyle. It's a very, very sad state of affairs. So therefore, the third type of diabetes is going to be a prediabetes or more a preventative. So when we can see the onset of diabetes coming, then maybe we can start to alter some smaller life changes before they have to completely give up all artificial sugars and different food groups, and still maybe help them maintain a balance. If we're able to help somebody the moment that we recognize that they're pre-diabetic, then we can help them cut out some of these little food groups, some of the drinks that they have, and help them get back into a better quality of life. And you guys, that's really what this is about. When humans are adaptable, it's absolutely amazing. People will live with pain for years and years and years and forget what it's like to not have pain, or forget what it's like to eat and not feel crummy afterwards. So it's very important that if we can give them a glimpse into what life was like, then it's easier to get them into feeling better. And a lot of people don't understand that what they eat makes them feel bad. It actually causes disease states. So knowing this, then the transition should be easier. It should be a mind over matter, because you want to do it to avoid disease states. You want to do it for a better quality of life. But unfortunately, the opposite generally occurs. People feel that what they eat plays into their quality of life instead of actually diminishing it. Now, some patients do have a metabolic syndrome. Basically, they're susceptible to becoming diabetic, and I'll give you a great example for this. It's hypoglycemic, and I'm certain there are several of you that are hypoglycemic. I am myself. There's a term that my family often tells me, and that's hangry. When you become hungry, you become angry, and that's literally because your brain is not functioning correctly. You get fuzzy, not clear, foggy-brained, and therefore you start to get angry and short and irritated. So if you're hypoglycemic, you do fall into this category of becoming a higher range of obtaining diabetes. Now, even though this all sounds very dreary and dismal, there are a lot of different strategies you can do to help these states out and to avoid becoming diabetic. And I would be more than happy to discuss the multitude of nutritional things that you can do, lifestyle shifts, as like what I like to call them, because you don't have to go on to full-on changes and keep letting go of things that you love. You can essentially keep up, but do small shifts that can increase the quality of your life. So if you find yourself in this category and you're hypoglycemic, or you have some other metabolic disorders that are making you susceptible to diabetes, please approach me before or after class, or even at break time. I'd be happy to share some big tips that were given to me by a naturopath that has completely changed my life. And I can tell you right now, I feel better than I have since I was 12 years old. So love to share that with y'all. Now let's take a look at the specific glucose testings. First of all, we have a thing called fasting glucose. Now, I'm certain you guys can put this together, right? Somebody fasts for 8 to 12 hours, and then we check their blood sugar. Secondly, we have a glucose tolerance test, or abbreviated GTT, on your requisition samples. We do the glucose tolerance test by administering a large amount of glucose, or a large amount of shake. I'm sure every single person who's ever been pregnant remembers this wonderful drink that they had to drink in a short amount of time. So we will then take their glucose levels prior to administering the glucose shake, 2 hours afterwards, 3 hours afterwards, and we can do this at a variation depending on what the doctor would like to see. Also, gestational screening is that when somebody is pregnant, sometimes diabetes becomes onset just during pregnancy, and then after pregnancy, the diabetes is lifted. Here's a very important term: postprandial. Postprandial literally means after eating. And when we take the term for postprandial glucose test, we're talking about 2 hours after eating to be specific. So, as you can see, the second bullet says 2 hours post glucose drink. Now, the glucose drink can have different levels 50, 75, 100 grams of glucose. This depends on the size of the patient, the type of test that the doctor's running, and what the physician would like to see inside of the exam. Here is our normal range for glucose. Generally, somebody should be anywhere between 70 to 100. Really below 50, right in the 40s, we get concerned about hyperinsulinemia. When it becomes over 100, we start looking at that pre-diabetic stage, and if we can start cutting out or altering somebody's lifestyle to ensure that they kind of avoid diabetes. But if somebody has been fasting, that means they haven't ate anything for 8 to 12 hours, and they come in and they still have a glucose reading that is above or at or above 126, we will use this as a diagnostic tool for diabetes. As I just mentioned, there are two critical values that I do want you to remember and have in the back of your head going forward into clinical settings. And the first one meaning that if somebody had fasted for 8 to 12 hours and has a glucose reading at 126 milligrams per deciliter, and just kind of side note here, remember that milligrams per deciliter, I don't want that to mess you up or throw you off on your national exam. But if somebody's been fasting, they have a reading of 126 or above, and we consider that a critical value used in diagnosing diabetes mellitus. Secondly, if somebody has a postprandial test and their glucose reads more than 200 milligrams per deciliters 2 hours after eating, then we will consider them to be at a critical value and use it in the motion of diagnosing. Now, they do have to have 2 consecutive critical values before a physician will diagnose them with diabetes mellitus. Now, as we were talking before, we have a thing called hyperinsulinemia. When we overproduce insulin, this causes too much of a breakdown. We don't get the absorption of glucose, and we have a similar effect as diabetes as far as signs and symptoms, but the cause is different. Mostly when we're dealing with somebody with diabetes, they have an underproduction of insulin, or their insulin is just not working at the same level as it should. The A1C test has literally altered the way that we can treat glucose and how we can help patients and really discover what their main hang-up is in balancing their sugars. Is it a lifestyle change, or is it something else that's going on that we need to further diagnose? And what this A1C does is it actually tests the hemoglobin on your red blood cells. And if you remember, hemoglobin is the key essential function for red blood cells. That's what literally picks up the oxygen, hands it off for carbon dioxide, and circulates around our blood. So what we have done is we have a test now that can literally look at the hemoglobin on a red blood cell and tell how well somebody has been balancing their glucose over roughly the previous 90 days. Now, what's really cool is we have point of care testing that will do this, and if you guys remember that term, that means that we get immediate results right there at the bedside. So we don't even necessarily have to draw this, but we do draw this out in the field. This does come from a lavender top tube, EDTA additive. And if you think about the principle behind it, we are literally looking at shape, structure, size of hemoglobin. Anytime we study blood that well, it's a hematology study, and that falls in our category of lavender and EDTA. The xylose tolerance test is really determined to see if somebody has an issue with absorption. So meaning that we want to see how much of the sugar is actually put into the bloodstream versus is being excreted. So for the D-xylose test, or what's also referred to as the xylose tolerance test, blood and urine is tested. This way we can dial in what is literally just passing through the kidneys and being excreted and what is being absorbed and put into our circulatory system. So it can be very, very powerful in helping us to find out exactly what ailment somebody has. Now, bleeding time test is, in my opinion, a little bit archaic, meaning that it's not a test I've seen done for a very long time. Essentially, let me just run you through the process, is that we will make a small incision in somebody's forearm. At the same time, we will start a stopwatch and we will take a circular filter paper and slowly dab the incision until they have completely clotted. And this is what we refer to as the bleeding time test. And so we literally see how long it takes somebody to create a clot. Now, as you can imagine, if you have this test done several times, you will have small scar incisions all the way down your forearm. And in my opinion, it's no longer necessary. Technological advancements have given us the PT-INR machine, PTT, and essentially what that means is that that is a point of care test or CLIA wave test where we can take a capillary puncture of blood and put it onto a device that looks very similar to a glucometer, and it will give us the bleeding time. It will tell us how long it takes for those factors to be enacted and for coagulation to begin. So we no longer have to rely on bleeding time, and therefore I don't want you guys to spend a lot of time even thinking about this, but what I'd like you to do is kind of tuck away this platelet function assay and think anytime you hear platelet function assay, clotting assay, factor assay, anything that goes along with coagulation, I want you to be linking to the light blue tube, the additive sodium citrate, and just automatically seeing coagulation as light blue, coagulation as sodium citrate. Anytime we are testing clotting in any nature, we want to link it to those tube colors, or well, to that tube color, I should say. As I mentioned before, this test has been replaced by many different options for specimen collection and is really no longer done or practiced. Blood cultures. Now, we've talked a lot about blood cultures and what blood cultures mean. First of all, I just want to reintroduce the topic of sterility, right? When we have a sterile procedure, this means that we destroy all microorganisms present. Particularly with blood cultures, this is very important because we are looking to see what type of bacteria the person has inside their bloodstream. And if we have any other bacteria on the outside of the skin, when we enter in, we could be introducing that new bacteria into our specimen. We end up treating the patient with something they don't actually have. We all know the complications for this, right? The patient will still get sick. We won't be able to accomplish anything. So just remember, blood cultures are a sterile process and they are used to detect bacteria or infection inside of our bloodstream. Now, I want to talk a little bit about the two bottles that are present for this, and that's aerobic and anaerobic. So essentially, whenever we're going to do a complete blood culture test, we're going to draw the aerobic and anaerobic. Aerobic is just simply implying that it has oxygen or allows oxygen, because we have two different types of bacteria, gram-positive and gram-negative. Gram-positive generally needs oxygen to survive. Gram-negative generally will die or cease to exist if it's exposed to oxygen. So if we don't draw those two bottles together, we could have a gram-negative presence and still not be able to treat that. So it's very important. that we do collect both of those bottles, and as you can kind of infer, aerobic is going to come first because there is a little bit of air inside of our needle. So no matter what we do, when we put on our tube, we're going to be introducing oxygen into that specimen. The thought process is that there will be blood then inside of our needle, and we go ahead and put on the anaerobic, then we minimize or even completely reduce any oxygen being put into that specimen. Here we see the blood culture kit, and remind me when we are in class, I have several of these. I'd like to show you how to use them in person. But essentially, whenever we're doing a blood culture, to reduce contamination and to create a sterile environment, we do clean twice. We clean once with isopropyl alcohol, allow that to dry, because remember, the drying of the alcohol is what actually enables the antiseptic to work. If you don't allow it to fully dry, then it hasn't actually killed or reduced the microorganisms. And then we go ahead and we use the betadine iodine, and we literally paint it 3 to 4 inches, the same diameter that we use to clean as well, and we allow that to fully dry, and then we go ahead and go forward with our draw. Another thing that I want to point out here is when you're doing blood cultures, you also need to clean the tops of the bottles with the alcohol swab. Do not use betadine iodine to clean the tops of the bottles. So this just ensures that we're not introducing any other bacteria into the specimen. We can use any method of collection for blood cultures. We can use syringe, or we can do evacuated tube system and hook the aerobic, anaerobic bottles directly on. We can use a winged infusion system collection, and then of course we can collect indirectly into isolator tubes. We want to try and avoid syringe if we can in these instances, just because it is extra transfers. It just gives way for more introduction of bacteria. It's not something that we can't do. We still can, but just keep that in mind. When you're out in the field, we do want to try and avoid that. Here we just want to reiterate the fact that that is an aerobic bottle and an anaerobic bottle, and they must be collected in that order, aerobic to anaerobic, and you do need to clean the tops of these with an alcohol pad. What I would suggest is that when you clean the top of it, you flip the alcohol pad over and rest it on top of the aerobic bottle, and then once you clean the anaerobic, you do the same thing. You flip the alcohol pad and rest it on top. That way when you go to draw blood, all you have to do is pick up the bottle, kind of flick the alcohol swab off the top of the bottle, and this enables you, or I should say, should give you the confidence that you haven't introduced any other outside bacteria into the specimen. Now, very similar to the light blue tube, where we have to fill with a 1:9 ratio, or in other words, 90% full, the blood cultures do have a typical level where they need to be filled. We don't want to overfill them or underfill them. We want to hit right at the 8 to 10 milliliters. As a beginning phlebotomist, this may be difficult for you to tell when they're reaching that mark. So using a butterfly will help tremendously, because you can keep the bottles erect and upright and then hook on the top hub of your butterfly into that and watch it fill, and then go ahead and pull it when it comes to 8 to 10 milliliters. Now, the milliliters are labeled on the side like a ruler system, so that you can tell the moment that it reaches these levels. It is suggested that you make a mark on the bottle so it's easier to tell in the middle of your draw. When you hit that level, then you can go ahead and pop off. What happens a lot is if you're doing a straight draw and you're filling these bottles, you do kind of have to have presence awareness of how full the bottle is when it's leaning sideways. And I'm sure that seems a little bit ridiculous right now, but as you draw blood and as you become more familiar with this, you can tell when the when you're holding the tube sideways and the back portion is completely full, you know when you stand it erect, you're going to be about 3/4 full. And just little things like that will start to click for you the more and the more you do this. Just one of these things where you do want to pay close attention so that we can give the best samples possible to the lab. TB testing is very important, particularly here in the States. We will always be tested every time we start a new job. Some jobs will test you every 2 years on the dot. It just really depends on where you are working at. But essentially what they do is they take a very small needle, the same as pretty much an insulin injection, and they go underneath your dermis into your intradermal, and they create a little tent, and then they push in the PPD, the protein derivative, and it creates what we call a wheal, W-H-E-A-L, and then the wheal is read for positive or negative. This wheal or raised bump will be read 48 to 72 hours later, generally by an RN. That is what the legal statute states, is that an RN needs to read this. A big fallacy of this test is that it's the redness. It's if this wheal becomes infected, then we know you have TB, but that's not necessarily the truth. The truth is that it becomes very hard and almost as if somebody has inserted something underneath your skin, and that's how we know. And as it gets hard, it will also swell, as we'll see on the next slide. And we look at the hardness and how much it has swollen, not necessarily if it looks red or infected. People can have slight reactions to the protein derivative, and that doesn't necessarily mean that they have TB. But it is not just taken lightly. If somebody does have the hardness and the swelling, then we will send them in for x-rays, and we will look at their lungs to make sure there are no visible nodules being present, and that's just a clear sign of tuberculosis. If somebody is found to have tuberculosis, we will quarantine them, and we will make sure that it does not spread. As I just mentioned, we don't just take this one reading and classify somebody and quarantine them and pound them with medication. We do send them down for x-rays and ensure that they are not having any type of infection inside their lungs. Interesting thing to note here, most people who are born outside the United States have been exposed to TB will come up with a positive skin test and then a negative x-ray. Goes along those same lines with vaccinations. At some point in time they are exposed to it so they can overcome the ailment, but they still are considered to be a carrier. So we will always kind of continually test them for that. We do have alternatives for testing for TB other than doing the intradermal injection and x-ray. We can take a blood test, and actually there's two different types of blood tests that we can do. We can also take a sputum test, as we're going to see here later. But one thing to always remember is that if somebody is in TB quarantine, we must wear an N95 respirator to keep ourselves protected, because the microns inside of TB are so small that they will go through most respirators or mask coverings that we wear. I did mention as you were going through your tours and as we were talking about the syllabus that we would be collecting more things than other than blood as phlebotomists. And so the other thing that we're going to collect the most is urine. Urine is the most collected bodily fluid outside of blood. So it is something that I want to encourage you to get used to, and just remember wear PPEs. Even though OSHA doesn't classify urine as a potentially infectious material unless there's visible blood, I want to encourage you to treat it as though it is. Now, one thing that always is pressing about doing any other bodily fluid collections is that it's not really up to us. we instruct the patients the majority of the time to go collect the sample and then bring us the sample back. So their understanding is absolutely necessary to get solid samples and to diagnose correctly. So I like to have a thing that I call the feedback sandwich. So I will let my patient know what I'm expecting of them, and then I will ask them to repeat back to me. And if they miss a step or anything like that, then I will repeat again, have them repeat back to me, and we just keep going back and forth until I feel confident that they actually understand the process in which I'm asking them to do. The other thing that I do, because there are some people that unfortunately can't keep up with a 7-step process, or it's becoming obvious that they are not going to do the procedure correctly, I will literally write on a napkin and star or even highlight, underline those specific things, steps that they were having troubles memorizing. And that way I can feel confident when they go into the restroom to collect a sample, they can refer back down to my steps and will bring me back a collection. Now, I don't just take that as face value. When they come back with the collection, I have them repeat what they exactly did inside the restroom and how they obtained the specimen. It's very important that we take a lot of responsibility for this, even though we're not necessarily the ones that are leading this procedure. I do want to take a quick moment and just point something out. When we are collecting any sample, it needs to be in a sterile container. It needs to be sterile. It sounds silly, but I can't tell you how many patients I would hand a collection cup to and leave the room to go get the rest of the kit, or prepare the next room for them and get everything ready, and then come back and they have the container wide open, they're playing with it, they might even suction cupped it to their face, multitude of different things. We have instantly broke the sterility, and that's going to cause false positives. So anytime, just let the patient know, do not open the sample until you're ready to put it in there. Anytime any of the sample stickers or seals have been broken, we can't guarantee the sterility, just grab another sample cup. It's not worth risking that for the patient. Now, these are different types of urine sample collections. So the first one is called the first morning, and you can imagine this, it's the first void or the first urination of the day. And the most common test that we pull out of a first morning sample is a pregnancy test. It's just the most common, most concentrated point of what protein is released, or I should say hormone is released, called HCG. And so we have the highest count of HCG and can easily diagnose, not diagnose, but easily tell when somebody is pregnant. Random samples are done exactly as they sound, randomly. A lot of the times these are correlated with drug testing. Double voided literally means the second void of the day, or the second urination of the day, and we want this to be 45 minutes to an hour after our first void or first morning specimen. This plays into the 24-hour collection. What a 24-hour collection is we will literally collect urine for 24-hour span, and every single time we collect it, we put it into a large container. This container needs to stay on ice or be refrigerated to help preserve the specimen. Now, why I said the double voided is connected with the 24-hour collection is because we don't want to use the first morning sample to start the 24-hour collection. So let me give you a real life scenario here. Let's say Mr. Jones wakes up at 7 a.m. in the morning, has his first morning void, has a cup of coffee, and is ready for his second void at 7:30. At 7:30, we will then start collecting the 24-hour collection. We will collect every single urine that is put out up until 7:30 a.m. the next day. That even includes the first morning that happens the next day. We just don't start the 24-hour collection with the first morning specimen. So therefore, 24-hour is pretty simple. And I do want to just point out that the 24-hour collection is collected for bacteria and to see what type of infection is present. One other thing to key note here is that when we are preserving these type of specimens, we do set them at refrigeration, which is 5 degrees Celsius. 5 degrees Celsius. That's an important number to remember. We store blood and urine at 5 degrees Celsius. Clean catch midstream seems to be the most difficult collection for patients to follow. And I think it's named very appropriately, the clean catch midstream. What you do is you take a chloroxidine pack, and once again, I just want to reiterate here, we are dealing with the peri area or private area, so using alcohol is inappropriate, using betadiene is inappropriate, using hydrogen peroxide is inappropriate. Therefore, we're left with chloroxidine or benzochlorium chloride, one of those two, generally chloroxidine. And if you're not familiar with this, I like to use kind of a terrible analogy, and if you've ever eaten ribs at a restaurant, they give you these wet nap packs where you can clean yourself up afterwards, and that's essentially what chloroxidine is. Now, the clean catch midstream, or referred to as CCMS, is where we open that up, we take one edge of the chloroxidine wipe and we clean one side of the labia, then not using the same corner, we use a different corner to wipe the other side of the labia, and then we want them to urinate enough to push out the urine that is in their urethra, and then we want them to clean one more time, of course reiterate front to back, and then catch the rest of the urine. And as you can kind of tell, what we're trying to do is see what is present inside the bladder. So this is a procedure that we're trying to detect bladder infections. And so therefore, if we clean the outside of the labia and then we allow the urine inside the urethra to exit, and then we clean once again, then everything that's collected at that point should be coming directly from the bladder, and then we can diagnose UTIs and different things from that process. But like I said, this is one of those ones you definitely want to ensure the person has understood the process and is going to do all of those little steps and clean the entire way. Otherwise, we could be introducing excessive microorganisms into the specimen, and we will not be giving the correct medication. And if you have never had the pleasure of experiencing UTI, it's very similar to having the flu. It will put you down, it will give you aches and pains. It's a very rough thing, so we definitely want to help people out as soon as we can with that. Now, catheterized urine collection is when somebody does have an indwelling catheter, and if you're not familiar with this, we do stick a tube inside of the urethra and then blow up a ball or a balloon inside of a person's bladder to ensure that that tube doesn't slide out. And therefore, when any urine is pushed into the bladder, then it goes ahead and it follows that tube out into the urine collection or the catheter collection. So with that said, when we are doing a catheterized urine collection, there is a double tube connection, and when you are changing the bag out from a night bag to a day bag, you actually hook this into the internal catheter. And when you are doing a catheterized urine collection, you unhook that. You want to put a clamp, or you want to put some type of rubber band to stop that inside vessel from leaking urine. We want to wait about 15 minutes, 20 minutes, come back, and then collect the urine directly from that indwelling catheter. And then always remember, hook your external catheter back up, because we can unfortunately cause disease state and hyperreflexia, where urine is then recycled into the bloodstream, and that can cause somebody to be very, very ill. So we have to undo that tie, hook on the external catheter, so that that can continue to flow into that bag, the catheter bag. Of course, when you're doing this, you do need to clean extensively. So you want to clean the outside of the internal catheter before you go ahead and collect your specimen from there. Also, you want to try and use some type of adhesive, and I shouldn't say adhesive, but it's lubricant when you're applying the external catheter back into the internal catheter, so that it is easy for the next person to take that external catheter off. And then we have what's called the chain of custody urine collection. We all know chain of custody. We just spoke about this. This is when it's going to be used in some kind of system of law. And so a lot of the times if somebody is having a drug test, then we will go ahead and do the chain of custody. We will fill out that extra form documentation that goes along with the specimen the entire time. Also with this, a lot of places have their own policies and procedures. I'll just share quickly with you the one that I used to do when I worked in this setting, and that was we would have the person fill up the specimen. There are temperature readings on the side of the container. This will allow you to know if there has been any foul play along with the collection of this. And we do want it to hit in a certain reading, and the thermometer on the side will let you know. As long as it's between this mark and that mark, we can go ahead with the sample. Then they will place a sticker along the top of the container, all along down the sides. They will have to initial and sign time and date that is the in fact their own urine that they put into that collection. And then we go ahead and process that all up, send it with documentation, have the courier sign that the courier is picking it up, and they take it to the lab for testing. And then of course we have urine culture collection. Anytime we hear culture, right, we want to think bacteria. We're growing something. We're looking at what type of microorganism is present, and therefore we will go ahead and collect this. Oddly enough, because we are allowing the microorganism to grow, urine culture can sit for 72 hours at room temperature and still good for testing. So just keep that in the back of your mind. We can still use that. Otherwise, the majority of these things are going to need to be put on ice for preservation. As we were just talking about different types of urine collection, you can tell like the CCMS, right, is going to be pertaining to females. Males have a couple different things that we can do, particularly if somebody is bedridden, by using a urinal and different things like that. And then also children, it can be a little bit more tricky to catch a urine sample from an infant, for example, but we do have various different equipment and things that will assist us in this process. With all specimen collection, there is a prompt responsibility for the phlebotomist to get this specimen to the lab in a timely manner. So for example, if we do not meet this, we don't store it correctly, we can cause deterioration of chemicals and cellular components inside the urine, giving us false readings. We can multiply bacteria at a rapid rate. We can decrease or increase the analytes due to bacterial growth in the specimen. So in other words, we still want to treat this very, very highly, and we want to ensure that this makes it to the lab in a timely fashion, that if it needs to be put on ice, we're putting it on ice. If it needs to be transferred into a preservative tube, then we transfer it into a preservative tube. And just very, very important that we treat these as well as we treat blood and other various bodily fluids. Now here's some precautions or kind of heads up, different things to keep in mind. These all are very important things. For example, like we've talked about before, refrigeration of sample must be at 5 degrees Celsius. This is very important in preserving the sample and ensuring that we get the most accurate results. Also, we want to use patient kit for clean collection, meaning that somebody's not trying to use a soapy rag or something that's not sterile or something that we can't guarantee is going to give us the best possible specimens. We also want to use special preservative tubes. On the next slide, we're going to have a picture of these, but essentially these preservative tubes will stop bacterial growth. They will preserve different metabolic syndromes and states inside of our urine so that we can get accurate testing results. We also want to use amber containers for 24-hour collection. Just like when we're doing bilirubin, amber protects this from light. This can also keep our sample as close to as it was inside of the body as it can be. And then we can also use chemicals in 24-hour containers just like we use them in our preservative tubes. When I worked out in the field, though, we generally just used ice, but this will be a physician's preference. And if they do want to use a 24-hour urine container with chemicals, then essentially you get to do the same thing. It may not be necessary to put it on ice if there are chemicals present. I always recommend doing that just because it will help preserve it and will give the best possible specimen. Here's a picture of those preservative tubes. Now I do want to point something out here. When you see with the yellow and red, they do have pointed tips. Most of the time our blood, well almost all of the time, our blood evacuated tubes are going to have rounded. With these, in urine collection, or I should say urinalysis, we will centrifuge the urine. This will push all the sediment into these little pointed edges, and then we can pour off the urine and look at that sediment under the microscope and really determine what is present inside of this person's urine. This kind of long straw looking thing is a double-edged urine preservative, meaning that inside of that hub there is a needle. So you go ahead and you stick the straw into the urine, and then you put the evacuated tube, urine preservative tube, in there, and it has the same vacuum like our blood evacuated tubes do, and it will suck the urine into there. So therefore you don't have to necessarily deal with splashes or sprays as you're transferring urine. And then it will go in there and that will preserve it for 72 hours or however length of time. This particularly helps if the lab is across the nation and we need to ensure that the urine sample is going to be viable when it arrives. Here is a 24-hour collection container. This one does use preservatives, and as you can tell, it is amber colored. It doesn't allow light to penetrate it. So just to reiterate, you will literally pour every single void for 24 hours into the same collection container, and then at the end of 24 hours, you will take it down to the lab, and the lab will analyze it. A lot of the 24-hour collection containers that don't have preservatives will actually be able to sit inside of a basin. So if you take this container here and you turn it sideways, and then you move the cap onto the side of it so that the cap is facing upwards, you can set that whole thing in a basin of ice. And that's what we used a lot of the times out in the field. Semen can be tested for several different reasons. For today's talk, we are really focusing on fertility testing. And a lot of the times we do fertility testing for post-vasectomy testing. And if you're not familiar with that, that just means when a gentleman has decided not to reproduce anymore, they will go in and they will remove, or I should say hinder the capabilities of sperm passing into the capabilities of transferring. And so we will then take different types of semen samples to ensure that the vasectomy actually worked and that individual is no longer capable of reproducing. A couple of things to really note here: that semen collection must be kept as close to body temperature as possible. It cannot be exposed to extreme heat, cold, light, anything like that, because then it will affect our swimmers and we will not get the most accurate fertility testing. We also want the person to bring us the sample as soon as possible. If the lab does not receive the sample within 2 hours, it's null and void. We can no longer test it. As it says here, we want it brought to lab within 30 minutes. We really want it immediately. Because of the nature of this test, there are a lot of individuals who don't want to produce the sample on site. They'd rather go home and produce the sample and then bring it back. So it's very, very important that you reiterate to them, we need this sample as soon as it is collected. This may seem a little bit funny, but I do think it is something to be mentioned here, is that we cannot have saliva with our semen sample. That will interrupt our testing and will throw everything off. So you do want to let your patients know about that. There are other various little things that go along with this testing, but all of those parameters will be discussed by the physician. It's just important that we follow up after the physician and ensure they know to bring it back to us immediately, to keep it out of light, to keep it as close to body temperature as possible. Those little things just to ensure that they are going to bring us back the best specimen possible. Throat culture. So once again, we hear that word culture. This means that we are going to grow or assess the microorganisms that are on the throat. So the way that we do this is if somebody says ah, we can see two sets of tonsils on the outside of the throat, and then we have the uvula, the dangly thing in the back. Now what we want to do is we want to take our very long Q-tip, and we'll see a picture of this on the next slide, and when somebody says ah, and they have a sore throat, they will generally have what we call angry red, raw spots on their tonsils, and we want to go ahead and swab those. Also, people will have pus pockets, these little white pus pockets. We want those. Swab that. And when I mean swab, I mean you're literally twisting and turning the end of the Q-tip on these spots so that we're collecting as much of the microorganism as we can. We want to collect left, then we want to collect right, and then this is the part that generally makes people gag, is we want to do a Z in the back of their throat and get out. It doesn't have to be a excruciating Z. We don't have to take a long time. We can be very quick with this. We just want to pick up anything that might be resting on the back of their throat. And then be wary, this is the part that generally gags somebody. You want to come out as soon as possible. If somebody has a poor gag reflex, of course you're going to be sympathetic to this and you want to make this a faster process. You also may want to plan ahead and pull a trash can near in case they do have emesis or vomiting after this. We also swab the nose. We're going to practice both of these in lab, so just for today's talk, essentially what you're going to do is you're going to stick the Q-tip up the nostril until you feel a little bit of resistance, and then you're going to swab, meaning twist and turn and make swirls, small into larger circles, and then also come out. And once again, this does cause discomfort for your patient, so we want to do this very quickly. Here we see those long extenuated, what I'm calling Q-tips. Essentially they are just sample collectors for us. We generally will do 2 Q-tips at one time, and the reason why we do this is because we have POL, physician-operated laboratories, where we will take a strep test, flu test, mono test, and go ahead and stick one of these Q-tips in there, add our additives, and essentially wait 5 minutes to see if they're positive or negative. But those aren't always accurate. So we take our second swab and we go ahead and we put that into a container. I'll show you guys all this when we go to lab on Wednesday night, and then we will label that up and send it down to the lab. I don't know if this has ever happened to you or one of your children, but you go to see the doctor, the physician says, no, you don't have strep throat, Please rest, drink fluids. You should get better here in just a little while. But then 24 hours later, you get a call from the pharmacy saying your medication is ready for you to be picked up. Well, what had happened on the back end is they had sent that sample down to the lab. The lab cultured it, grew the microorganism, and actually identified that yes, you did have strep throat. And then the physician, upon receiving those results, went ahead and called in a prescription to help you. So even though the physician operated laboratory, the little strep test that we did, the 5-minute rapid test, came out negative. In fact, you really did have a infection present that needs to be treated. And so that's why we always run 2. Sputum collection. So I know a lot of people get a little squirmy when we talk about mucus, phlegm, loogies essentially, but it is something that we do test really fast. Before we even go a little bit further with this, I just want to point out that if you're going to collect one of these samples or you're dealing with patients like this, just be very wary. Make sure that you're generally very contagious at this point in time, that you're taking care of yourself and you're protecting your family at all costs as well. You don't want to bring home things from work, especially things that are going to be damaging to your family. So first of all, we don't want to collect saliva. I really want to stress that here. This is not a saliva, this is a sputum collection. So when somebody does this, they do need to breathe deeply into their lungs and then cough up or bring up the mucus from inside their lungs. We really don't want to oversaturate the sample with saliva. It's not going to do us any good, and in fact it can hinder the sample. Now we do want to have the patient rinse their mouth with just water. That's it. So therefore, if there's any excessive or added grime inside their mouth, we can get that out before they give us the mucus sample. We don't want them to gurgle. We don't want them to use mouthwash. All of these things could interfere with our sputum test. We just simply want them to rinse. That way, if there is anything, we get it out and we can just test that pure phlegm, pure mucus. Stool samples are somewhat common, so I just want you all to brace yourselves with that, and we can talk more about this in class. I'm sure everybody's ate Brussels sprouts before, or something they didn't want to. You know, when you shut off your olfactory senses or your smell, then you are capable of overcoming a lot of different things. Just remember, your patients are just as embarrassed about this as anybody else, and so it's very, very important you act professional and you make them feel comfortable and you're there to support them. It's not about you. I just want to reiterate that. So first of all, when we take a stool sample, we generally will collect it in a hat inside the toilet. We cannot mix urine with our stool. Urine will kill a lot of the bacteria that we are wanting to test on the stool sample, so ensure that these two fluids are kept separate. When we're doing a stool sample, we are looking for occult blood, parasites, and colorectal cancer. Those are kind of our top things that we're testing a stool sample for. Here is a common stool sample test. In fact, a lot of these are being replaced nowadays. This is becoming a little bit older technology, but essentially what you do is once the stool has been collected, we take very much what looks like tongue depressors and we smear a sample in these half moon places, as you can see on the picture here, and then we go ahead and set that into a biohazard bag and send that in for testing. This is generally done at home. This is most of the time a home test, and this one in particular is looking for blood inside of the stool. These are special containers that we use for stool samples. If you can see here, there is a spork-like thing on the end of the lid, and really all we do is take a good scoop of the stool sample, and then we go ahead and tie that on or twist that back onto the sample. Now, I am going to just be kind of a little bit crude here, and a lot of the times when we're doing these samples, there's going to be a lot of mucus mixed in. We do want to try and get as much fecal matter as possible to actually test and collect. A lot of the times when I was out in the field, when we would send the mucus down, the lab would come back, reject it, and say, sorry, there's really nothing for us to test here. And so it's very important that you go ahead and get the fecal matter. Another thing I do want to point out here is C. diff is spread through fecal matter, spread through direct contact. It is also airborne. So anytime you're dealing with collecting a stool sample, please put on the appropriate PPE, protective equipment, and ensure that you keep yourself safe. C. diff has now become a superbug and is becoming more and more of a serious ailment. Okay, class, that does take us to the end of Chapter 9. Like I said, this was a little bit more heavy of a chapter. There are a lot of very important things. Hopefully you caught all those important things that are going to help prepare you for your national exam. And please prepare any questions that you may have. I will be happy to start the class Wednesday night with all of your questions and address everything. I, of course, want you guys to feel very comfortable with this material before we move on to our next set of things. And also, just so you know, for the rest of our timeline here, 10, 11, and 12 are very short chapters. We will probably finish them all together. I have deemed December 10th to be our CPR class, so just mark your calendar, make sure you do not miss that day. Very important that we also start on time that day because CPR will take pretty much the entire class time. A couple critical questions or things just to think about. How do you feel about these extra bodily fluid collections? Do you think there'll be any more, like cerebrospinal fluid, synovial fluid, different things that you'll be asked to assist and transport specimens for? So just to keep a train of thought. Also, we will be going over the questions that follow on Wednesday night, and we'll be going over the questions at the back of Chapter 9 as well. So look forward to seeing y'all next week. I hope you guys have a fabulous Thanksgiving. I am, once again, just want to say how grateful I am to have a class like you guys. You guys are doing amazing. Please don't hesitate to email me or text me any questions, or if you get stumped with everything. Happy holidays. Many blessings.